Good evening, everybody. Thank you so much for joining us. Dr. Avula and Rebekah, thank you so much for being with us again. It's good to have community together. I kind of wish we could be together in person and not have to keep doing COVID update calls. I thought we were past it, but the beauty of our community is one that we have always relied on and kind of leaned on each other. And we will do that now as well. The format of the evening is I'm going to ask Dr. Avula and Ms. Butterfield to give us some opening remarks. I will be, along with some of my colleagues, monitoring the chat, and we will ask you to put your questions in the chat. I will ask, maybe give them some time to give you their intro first, because my guess is some of the conversation will come in there, and we'll work through as many of the chat's questions as we can. We've booked Dr. Avula through midnight and Rebekah through 2 a.m., so we should be good. We'll solve the world's problems from then. Again, my name is Daniel Staffenberg. Thank you for joining the Jewish Community Federation of Richmond. And I'm going to bring everybody on screen so you can see our wonderful guests, and we will go from there. Dr. Avula, as many of you know, is the head of Richmond and Henrico's health department, has become the COVID czar for Virginia, and we are grateful to his and everyone involved's leadership in making Virginia one of those states which seems to be doing a little better than most, so thank you all. And Rebekah Butterfield is our new friend, epidemiologist, member of the team at the Department of Health, and we're really grateful for both of you. Dr. Danny, let me start by saying, can you give us an update on where we are right now, what you expect for at least the short term here, and what we can do both on the vaccination front, as well as kind of our current local situation?
Sure will, Daniel. Great to be with you all. I want to give a shout out to Helen Griffin, who seems to be taking precautions very seriously. No, it's great. Great
with a COVID case in her family. So
got it. It's great. Well, I mean, unfortunate, but good to see you joining this call in the midst of that, Helen. And then yeah, just so many names on here, folks that I've gotten to know over the years, and so really glad to share this space with you. So where are we right now? Delta is surging, and we had a really great June, beginning of July. Hopefully folks got away and on vacation and got to enjoy the context of very low case rates. But we have seen the emergence of this new and incredibly contagious variant that has dominated the global outbreak scene. Certainly in Israel, in Europe, we saw the Delta variant become the dominant strain. It did so very quickly here in the United States. Over the course of a couple months, really is now more than 90% of the new infections that we're seeing. That also has led to increased cases. About, from this past week over last week, about a 40% increase in cases, about a 25% increase in hospitalizations, and about a 25% increase in deaths nationwide. So we really are seeing this take hold here. And it's really being driven by some of our southern states where we had low rates of vaccination, less than 30% of those residents in places like Florida, Louisiana, Alabama, Arkansas, and now that's where we're seeing the outbreak being driven. So what's different about Delta? It is much more contagious, as I said, and the reason it's much more contagious is the way that this virus replicates. There's a really significant increase in the amount of virus that's actually made in your body once you're infected. And so as they've done studies over the last month looking at viral load in infected individuals, it's 1,000 times greater than the viral loads of people with the Alpha variant. And so because of that increased virus, you are therefore much more contagious. It's that much easier to spread it to other people. Now, this has been true, and sort of recent outbreaks have documented this, and this is kind of a concerning change. This is also true in people who have been fully vaccinated. So before, in May, the CDC said, now there is plenty of evidence to show that people who have been fully vaccinated, they no longer need to wear masks in public settings. And that was welcome news for so many people. And now here we are just a couple months later saying, okay, new evidence because of this new variant is taking us back a bit. And even fully vaccinated people have been shown to transmit this disease. And so therefore the CDC updated its recommendations about a year and a half ago, saying, a week and a half ago, a week and a half ago, saying that even fully vaccinated people who live in communities where there are high rates of transmission, they should wear masks in indoor settings. And so, in synagogues, in workplaces, in schools, you're going to see those recommendations start to come about of going back to requiring or strongly recommending masks, even if you're vaccinated. But I guess one of the take-home things I want to make sure everybody comes away with is, even though Delta is way more contagious, that Delta can be contracted and spread if you're vaccinated, what we are still seeing is that people who are fully vaccinated who become infected are significantly less at risk to get hospitalized or to die from this virus. And so vaccination is still absolutely the thing that is going to protect us from the severe consequences of this disease. And ultimately, when we get enough people vaccinated, we'll be able to move on from a lot of the mask wearing, the distancing, all of the concern we have, because, when we get enough people vaccinated, we no longer have to worry significantly about those severe consequences. So there's a few things on the horizon in the vaccine world, and as we think about this Delta variant. One, there's breaking news just in the last half an hour or so that the FDA will likely make a recommendation in the next 48 hours on third doses in immunosuppressed individuals. So this is a question a lot of people have had, especially as we've seen Israel announce that it's going to start, or it actually last week started administering third doses to those who are immunosuppressed. United Kingdom and Germany have followed suit. They said they're going to start that in September. And so the FDA has really sort of prioritized the review of that data. And so we expect an answer sometime in the next 48 hours about if and when a third dose is recommended and who would fall into that category of immunosuppressed. So more to come very soon on that. I do think it will be a fairly narrow designation of people who have specific conditions, perhaps bone marrow transplants or on cancer therapy. So we'll see what comes out, and we'll make sure that people know and understand what would make you eligible for a third dose. Probably in the next couple of months, we will see that third dose recommendations start to expand to other high-risk categories, like the elderly, like those with underlying conditions, like those who live in congregate care settings. I don't expect that to be part of the prioritized group in the next 48 hours. So we'll see what happens there. Another big moving piece is the approval of vaccine for kids under the age of 12. So right now we have a vaccine that's good for 12 and over. Clinical trials have been in progress for the last few months. They've been really promising. And Pfizer is going to submit its data sometime in the month of September. So depending on when they get that data into the FDA, the FDA will probably need 2 to 3 weeks to review that data. So we could see an approval for 5 to 11s as early as the end of September, or it could be into October. But really in the next few weeks, we will see that. Unfortunately, it won't come in time for the start of school, but I do think the fall will be, there'll be a big push through school-based vaccination, through pharmacies, then through pediatrician and family physician offices to ensure that population gets vaccinated. And then, go ahead, Daniel.
I'm sorry. And the feeling is right now that there is enough vaccine out there to meet the increased demand.
Yes, we are, we're in such a different place than we were in December, January, where supply was extremely constrained. So right now, based on the amount of vaccine the United States has accessible, there's no real concerns about supply demand mismatch like we had to deal with. So that's really encouraging.
Sorry.
Nope, no problem. So the last thing that is in process is a move from emergency use authorization to a full licensure by the FDA. And we've been waiting months for this. They've had Pfizer got all of their data submitted for review back in May. Moderna did shortly thereafter. And so, it's a really rigorous process because it's 6 months of data on tens of thousands of patients. Every page is reviewed, every I dotted, T crossed, every calculation reanalyzed. And so that's what has been the holdup in terms of FDA providing this full licensure, but we do anticipate that as well will happen sometime in the month of September. And so that's going to do a couple things. One, for the segment of the population that was a little bit concerned and saying, I'm not sure about wanting to get vaccinated because it's still under this emergency use authorization. It's going to remove that barrier for a lot of people. But the other thing that I anticipate it will do is make vaccine requirements much more normal. And we've already started to see that happen, right? The federal government a couple of weeks ago announced requirements for its employees. We're going to see that play out in the military sometime in the next few weeks. The state government, local governments have started to require that of their employees, and the private sector has been doing this for some time. And I think, as each domino falls, it's going to become more and more commonplace that employers are requiring this of their employees, both because it's the safest thing for people in the workplace, and then really sort of dealing with the operational considerations of people who are exposed, having to be pulled out, having to be quarantined, having to just deal with logistically, how do you make a business or an organization work when you've got that going on in the background. Did I already talk about Delta in kids?
I think you mentioned it, but I'd like you to fill in a little more.
Okay. So, the schools are going to be a challenge this fall because we're surging in cases right now. We are seeing the highest rate of pediatric infection and of pediatric hospitalization. Those southern states that I mentioned before, they're all seeing many of their children's hospitals really get strained in the face of this increased pediatric hospitalization rate. We're trying to figure out, is this consistent with the experience of Europe and Israel and other countries that have gone before us with this Delta variant? I didn't hear much, frankly, when they were experiencing their real Delta surge. But now Indonesia said they're losing about 700 children a day to COVID. Obviously, the healthcare infrastructure is very different there. And so, we're not yet seeing pediatric deaths increase, and we're not yet seeing this in Virginia. We've not really seen an uptick in pediatric hospitalization here. So this is something that feels new and different. It does feel concerning. It's something we'll continue to keep an eye on. I was on a call yesterday with the Secretary of Health for the state of Arkansas, which is one of the states that has experienced the surge. Their children's hospital, just as a point of reference, at no point during the pandemic had they had more than 6 people admitted for COVID. And even then, and this was my experience, I'm a pediatric hospitalist. I still work about, a shift a month just to stay connected to patients. But at some points we had, 1 or 2 patients that were admitted, but they were incidental. They weren't there because they were sick from COVID. They were there for something else and happened to screen positive on COVID. What Dr. Romero in Arkansas described, he's a pediatric infectious disease doc who also actually just rolled off as chair of the National Advisory Committee on Immunization Practice that makes all the recommendations. So really plugged into the vaccination conversation. But what he described on this call yesterday is that we are seeing kids who have acute respiratory disease. They're coming in because of that respiratory illness this. Last week, they had 21 COVID patients at the Children's Hospital of Arkansas. 6 of them were in the intensive care unit and 2 of them were on ventilators. And so it was just a pattern that really hadn't been seen in kids before. And so if this continues to be the case, it is going to, and probably already will, given some of the national media coverage around this, will generate a lot of concern and challenge in the way that we approach school reopening. So this is one of the big things that I think will be complex over the next few weeks as we try to balance the need for kids to be in person in school, but also to keep kids safe in the midst of a new foe here. So let me pause there. Rebekah, any gaps you want to fill in there before we jump to questions?
Nope, no gaps. We can jump to the questions.
Thank you both. The questions and concerns about the virus, the vaccination itself, kind of looking at you, Rebekah, the nerves about the speed at which it was brought in, and clearly that is a deterrent for some. And then also related to that, we know pending on 5 to 12, how soon after that do you think we will see vaccination for under 5 years old, or is that much farther off?
Yeah, Danny can speak to the when. I'm less involved in that.
So if 5 to 11 happens late September, early October, the younger age trials are taking longer because they have to scale down the actual dose that's administered. And so figuring out what is the right dose that still achieves the right antibody response is going to take more time. I don't think we will have an approved vaccine for that youngest age group down to 6 months, probably till the very end of 2021 or early 2022.
And then, go ahead, sorry.
No, I was going to answer your first question about, and just in brief, and certainly if this is a concern, we can hold another town hall. I can write up some materials, but there are a lot of concerns with vaccine safety, with how quickly it was perceived to be produced. But as far as Pfizer and Moderna, the mRNA vaccines, scientists have been researching mRNA vaccines since 2013. It's actually a vaccine modality that has had a lot of research. People have been looking into it a lot. There are other vaccines that are mRNA vaccines, and it really has proven itself to be quite safe. And I understand the hesitancy. I was just texting with my brother-in-law about this, who is very concerned about it as well. And one of the great things about these mRNA vaccines is that they are comprised of very few ingredients. And so you've got your bubble that holds the mRNA, which is made up of phospholipids, which is basically what your cells are made up of, right? So it's an inert substance. You're not going to have a reaction to that. And then the mRNA inside is just messaging. It's what your cells make every day, just giving instructions so that your muscle cells in your arm where you receive the vaccine then make the spike protein. And you knew that this was going to come in, Daniel, at some point. If this is your SARS-CoV-2, the little sticky outy bit here, and close the window so you can see, this is the spike protein. This is the only thing that the mRNA vaccine is telling your body to make. So you have to have a whole virus to be infectious and dangerous. The only thing that the mRNA vaccine is telling your muscle cells to make is this little bit. And so what happens is it's like printing off a bunch of posters and showing it to your immune system and saying, this is the wanted poster, this is the bad guy to look out for. And when your body is looking at, infectious agents or things that are not itself, it will easily recognize that spike protein and protect you. So that was the very short, why do we trust this vaccine? If you want in-depth on Johnson & Johnson, we can maybe go into it later. It's a different vaccine vector. It is still safe. But yeah, I hope that briefly answered that question.
Maybe I'd add one other thing that I think is a source of heartache for a lot of people that just feel like we faced this new virus in February of 2020, and by the end of the year had a new vaccine. That's way too fast. How can it be safe? And I think what Rebekah said about this being built on older, a body of work, mRNA technology really started back in the 1990s. Like that's when they started to work on building these platforms, and then had a couple of less successful runs with Ebola a few years ago, and a couple of different viruses. So this has been a body of work that has evolved over 20 plus years. And I think we really just got incredibly lucky that this version worked as well as it has with the safety profile that it's had. And so I think really reassuring people about this wasn't some newfangled thing that we just were able to come up with. This was built on decades of research and science.
Thank you both. That's helpful. And we got to see the fuzzy COVID. So that, a couple questions. One, are we seeing kids catching COVID from vaccinated parents or more from unvaccinated peers? So I think that goes into once you're vaccinated, if you're asymptomatic or you don't know, can you still pass on?
It usually works the opposite way. So usually if we see a vaccine breakthrough and an unvaccinated person and they're both positive in the same household, it usually comes through the unvaccinated person. We are seeing though, like Danny said, with the Delta variant, that vaccinated folks who experience post-vaccination infections do have higher viral loads than we would have expected from research with other variants. And so they are able to infect other vaccinated and unvaccinated people. And for the vaccine breakthroughs as such, we're also sort of noticing a trend that they tend to be associated with household exposures, so an ongoing exposure, although not in every case.
So it sounds like kids should still be both indoors and even potentially not outside wearing masks, regardless of their family's vaccination status.
Right, both to protect them and others. Mm-hmm.
I have not heard this, so this is new for me. There's a Lambda variant, because why not worry about so many different variants at this point?
Yeah, so the Lambda variant is, there's kind of two classifications the CDC uses: various variants of concern and variants of interest. The alpha, beta, gamma, delta are in that variants of concern category, and then they kind of keep an eye on things that are emerging in different places. The Lambda variant first identified in Peru. We actually identified the first United States case, I think like 2 or 3 weeks ago in Houston, Texas. Have not seen it really emerge as a significant threat, and that may just be in the context of Delta, which is so much more contagious, that it just hasn't had a chance to enter the milieu. But yeah, not much in terms of its transmissibility or causing more severe disease at this point. Something that we'll continue to keep an eye
on. Thank you. This is fantastic. I will share with the group that Dr. Danny and Rebekah both met with a small group of our Jewish communal leadership. It was like yesterday, but it was late last week. And we did go into deep discussion about maybe changing reopening plans, and as the Jewish community comes together for high holidays. I will tell you that many of our organizations responded to that with either some changes to their protocols. Can you give an overview of what the current recommendation is for vaccinated, unvaccinated in offices and closed spaces? What you would recommend at this point?
Yeah, so we don't have a mask mandate. So this is a recommendation from CDC, but CDC is recommending that even vaccinated individuals in communities where there is a significant amount, or either they have different levels, substantial or high transmission, wear a mask when with members outside of their own household inside. So in an office setting, in a school setting, if you're attending a meeting or a party, we're recommending masking, and really that's because of the increased infectiousness of the Delta variant and probably more vaccine breakthroughs with Delta. And then for unvaccinated, it's the same masking and distancing that we recommended before vaccines were available.
we spoke about Pfizer and Moderna, a little bit about J&J and potential boosters for them.
Yeah, so maybe let's talk a little bit about the concept of boosters for a second, because there's kind of two categories that we think about this in. One is a third dose for Pfizer, Moderna, or a second dose of J&J of the same formulation that we currently have. And that's the data that the FDA is reviewing right now. And those are the vaccines we have available to us. And so I do think now that sometime by the end of this year, we will see recommendations for a third dose of or second dose with J&J of the existing vaccine formulation. What is currently under development by all of the pharmaceutical, the manufacturers is, developing new formulations of the vaccine that incorporate the new variants that have the Delta variant and Alpha variant mixed in there. Just like we have a new formulation of the flu vaccine every year, because flu as a virus shifts, it changes. We see mutations, we see different strains predominating every year. So every year you get a new formulation of the flu vaccine. I think that's what we're going to see with COVID as well. We will likely have annual boosters that are formulated based on the dominant strains around the world at any given time. So that's not available to us yet. I don't think that will be available until well into 2022 probably. But we will start to see recommendations around third or second doses of the existing vaccines. We generally just have not heard as much around Johnson & Johnson. I mean, they're clearly still in the mix. The biggest reason we haven't, one, because in terms of scale, we had 350 million doses of Pfizer and Moderna that have been administered in the United States. That number is under 20 million for Johnson & Johnson. And so we just haven't had the same body of evidence to look at. And then the other thing is that they have continued to have issues with their production facilities. So you may remember they had a facility in Baltimore. They had to throw away some 17 million or so doses because they made some mistakes along the way. And so they still have not gotten that facility FDA licensed and up and running. And so I don't know. I mean, at some point they'll get it together and it'll be a part of the conversation again. But I don't see it happening anytime soon.
And this now comes to the crystal ball portion of the evening. What has to happen for us to get over this, and when? I believe you've talked about we currently don't have a mask mandate. I think previously when you and I spoke, we were talking about you don't see there's an appetite for a true shutdown like we experienced last March and April. But what are the trends where we can kind of get back to true normal life? And when do you estimate that might be the case? And we will not hold you to any guess. Point, we still appreciate you and love you, but I know some of us are trying to plan for the years ahead.
Absolutely. Well, a couple things. One, I do not think we will see hospitalization and death rates anywhere near what we experienced in December, January, February of this year, right? We had both an all-time peak of cases in a context where nobody had protection. There was no vaccine to be offered, and that's why we saw the daily death rates that we saw. Pretty different context right now, and that doesn't mean we won't see some, because even in Virginia, where we've done pretty well, of our overall population, we're about 54% fully vaccinated. There are other metrics. The president wanted to set a goal of 70% of adults with one dose by July. We beat that goal by a couple of weeks, and now we're somewhere just north of 73%. So it's been slow going. But the real marker in terms of disease transmission is how many available hosts do you have that can spread the disease. And that has been complicated by the Delta variant, because even now when you're fully vaccinated, you can still contract the disease and spread it. So I think the way that I and most of us are thinking about this is that the vaccine is the most important thing to be able to protect you from severe consequences, to protect you from hospitalization and death. In this context where we have so many people who are unvaccinated, masks are what are going to prevent us from spreading the disease and seeing these cycles of outbreaks that we're now starting to experience again. So the combination of the vaccine and the mask are going to be crucial in this particular period of time where we still have so many vulnerable individuals. At some point, hopefully in the not too distant future, we will have enough people who are protected through vaccination that we no longer need to worry about those very severe consequences of COVID, and we can kind of get back to normal, knowing that COVID will always be with us in the background. Now, Delta is so contagious that I think we probably will get over the next few months to somewhere between 90 and 100% of people will be exposed to Delta. They're either going to be exposed to it fully vaccinated, or they're going to be exposed to it unvaccinated. And our imperative is to try to protect as many of those people as possible through vaccination. So, we're going to continue driving that forward. And hopefully, at some point we get enough folks vaccinated that we no longer have to worry about people dying from this disease. And then we'll lose the mask mandates and social distancing at that point, or the mask recommendations and distancing at that point.
And if I can add, I did see in the chat, someone was asking if cloth masks can still stop the Delta variant. So I do want to address that, especially because Danny brought up masking. The actual size of the virus hasn't changed. The size of respiratory droplets hasn't changed. So we may not know exactly all of the mechanisms behind the increased infectiousness, but it's not about cloth masks are no longer effective. So, your respiratory droplets range in size from like 0.3 microns up, and a mask generally can stop a cloth mask 0.5 microns and up. So you're still catching the vast majority of respiratory droplets. And the virus doesn't travel by itself. It travels in that aerosolized is the wrong word, but in the respiratory droplets that are leaving your mouth, that's mostly moisture and germs and gross stuff. And so the masks do still really work. They are still catching those respiratory droplets. In hospital settings, in places where aerosolization might occur, we're still recommending N95s or surgical masks, but there's no need to worry that the cloth masks aren't effective. They still catch a whole lot of virus.
Thank you. There's some conversations about, are we going back? Do we still have the same guidance around, exposures and quarantining, as well as a little bit around symptom infections? Can you guys talk a little bit?
Yeah, I'll start. Rebekah does a lot more of this in the day-to-day, so she'll get into the details. But really, the pre-Delta, if you were fully vaccinated, you wouldn't need to quarantine at all because you were fully protected. There was really no concern that you were so low risk to contract the disease and spread it. In the context of Delta, we are seeing more. Every day we're seeing outbreaks here in Central Virginia where fully vaccinated people are having what are called breakthrough infections. So they're fully vaccinated, but they're still testing positive, but they're also part of the chain of transmission. And so they're because of the way Delta works with increased viral loads, they're spreading the disease as well. So how the guidance has changed is that instead of fully quarantining and going away for 14 days and keeping to yourself, you just need to wear a mask when you're around other people and monitor yourself for the development of symptoms. And then we would test all of those individuals. Anybody who has been exposed would be tested at somewhere between 3 and 5 days. Rebekah would like to wait a little bit longer just because sometimes it takes a longer for that virus to lead to full infection. So the quarantining guidance has changed. It is really reliant on us wearing masks to make sure that we're not unknowingly transmitting the disease.
Rebekah, you want to add in?
I completely agree with Danny. I'm going to go ahead and paste into the chat the CDC recommendations for vaccinated people, just because it's always helpful to have a go-to. And they've been updating it really well. So, you know, when guidance changes, they will update this page. And if they don't, they'll have a note at the top that says this page isn't updated, go here. So it's a really great reference. But yeah, I think, you know, we're still seeing that vaccination does help prevent some infections. So it's not just that, you know, everyone who is vaccinated and is exposed is definitely going to get sick. Vaccination is still reducing infection and symptomatic infection. I think the focus on this is more that vaccination is preventing hospitalization and death. And that's the whole point of vaccination and all of the mitigation measures, because we need to prevent those things. So as far as, oh, you know what? I didn't paste it into the chat. Hold on. I realized I didn't send it to everyone. Let me do that again. We are like, if a vaccinated person is exposed, and like Danny said, I give this recommendation many times every day, but if a vaccinated person is exposed, they don't need to stay at home. They do need to mask. And I also like to add that I'd prefer if they would stay distanced as well, because masking is great. It catches a lot of viral particles. It catches a lot of respiratory droplets. But the more effective thing is distancing. And so while we don't recommend that for vaccinated people on a day-to-day basis, if they know that they've been exposed for that 3 to 5 days while they're waiting to get tested, it's just better to be safe and keep your distance if you can. So that was the only thing that I would add to what Danny said.
So since we mentioned testing as part of this new kind of exposure quarantine procedure, and I saw a question earlier around how is testing evolving, what's its availability, it's worth spending a little time on that. So right now, you know, testing is really widely available. You can go onto Walgreens or CVS and probably, you know, same day or the next day, schedule yourself for a testing appointment. Health departments continue to provide testing options a couple of times, 3 times a week. Most private providers have access to testing, and now there are even home kits that you can purchase at a pharmacy, a rapid antigen test. It's about $20 for 2, maybe a little bit more than that. So there are a lot of different options for testing. I think we are right now working with school systems. There's a lot of federal money that's come in to support that, where there are testing protocols, kind of once or twice a week, rapid testing of the entire population, or sometimes more focused populations. We're still kind of working out those protocols with our local school systems. Employers are contracting testing agencies to provide that opportunity for their employees. So I think we're just going to see more and more of it. And, you know, we'll probably get to a point where we're surging in late August, September, where there'll be a strain again. But right now, things look really good. There are some more testing modalities at the national and global level that continue to, be researched, and I think we'll see new entrants into the market. There's a technology called CRISPR that is as accurate as PCR testing, but as quick as antigen testing. That's probably going to become a big tool that we use in the coming few months. Interestingly, Europe has started to use COVID sniffing dogs in their public spaces. They've trained dogs to identify COVID, and does it with 94% accuracy. So I know that there are some pilot projects going on around the country, and one here in Virginia. So, there will be some interesting things that emerge, but right now we're in a pretty good place as it relates to testing.
Dogs, masks. There's some conversation around flu shot and COVID shot. Is there a relation? Get them both? Do they interact with each other? Effectiveness?
Different vaccines for different viruses on different platforms. No reason not to get both.
And you don't have to, if you can schedule them the same day and get them both, and that's okay.
That's right. The most recent guidance from the advisory committee is that there's no need to space out your vaccines from other vaccines that you would administer.
If we're getting some questions, obviously, for the Jewish community, we're coming into the high holiday season. Many of us are desirous of being back together in our synagogues. A little talk, I know we did this with the professional group, but maybe share here. is it safe if you're vaccinated, et cetera, and then I'll say what I'm seeing from our colleagues and what they're moving.
Jump in here. Oh, sorry. Were you still talking?
No, I was waiting to see if you or Danny wanted to take.
Yes, well, I should just wait it out so Danny answers all the questions.
I noticed you were staying on mute. I was like, I know she's doing this one.
Well, I have to stay on mute because my dog keeps barking in the background, so I come off just in time. So yeah, we are, obviously we're really pushing vaccination. That's not a surprise to any of you at this point. And so, continuing to encourage your community and congregations to be vaccinated, to keep themselves safe, to keep the community safe. And then, the second thing we're looking at is making sure that folks are masking indoors with this level of community transmission, and that when possible, we're also distancing indoors. One of the things that I always recommend that I think often people don't think about is right before a large service or right before an event, send out an email blast and say, hey guys, just a reminder, if you've been exposed to somebody with COVID, if you have any COVID symptoms, please don't come to this service. Like, refrain. This is your way of expressing love to the community by, even if you don't think it's COVID, even if you think it's something else, this is how you can love your communities, by being careful in these ways. And that's a big thing. It really does help. And then retrospectively, I'm not a pessimist, but I will say that inevitably we will probably have an infectious person at a service. And so when that happens, just encouraging folks to report that to someone, to call the health department, to tell the local rabbi or somebody who can work with the health department to identify any close contacts, so that if there was an exposure, we can kind of keep it contained and keep it from spreading throughout the congregation. So those are the main. We did have a really wonderful discussion about whether or not we should mask the shofar in our last talk, and that was my favorite discussion. But as far as general mitigation measures, I do think that those are the most important. And with any specific questions like that, feel free to email me or give me a call. So you can throw my email address out there. I hope I don't regret that. I think it'll be fine. And I'm happy to work through those.
What we'll do to protect you and to help us. And if people have questions, they can reach out to me or one of my colleagues at the Federation, and we'll forward them to you. Not that you're not very generous with your time, but we need you doing your work as well. And we can.
Thank you. I appreciate that. Happy to help though.
I did enjoy our shofar conversation, and that was pretty inspiring. I will share that the messaging that I am hearing from some of our synagogue partners by no means is this descriptive of everybody, nor am I telling you exactly what they're doing. I encourage you to check. But I believe they have made changes that either they will only accept vaccinated. I know some of our synagogues have altered their plans to continue to live stream, but maybe won't be in such large numbers. So please reach out. And if you have friends and newer members of the community who are looking for a connection to a synagogue, it's a great opportunity to connect them virtually or to find a way to welcome them in. There's a very long answer about singing, etc. I think it goes along with what our a COVID expert, unfortunately, we've heard all along. Singing is one of those things that puts out many more droplets than others. Please mask, please be social distanced. We want to hear your beautiful voice, but we want to hear it for a very, very long time and not sick. I think those are the questions I am seeing.
There was a question earlier about the younger age group, about kind of preschool daycare settings, and this has been a challenge of late. We've actually seen an emergence of daycare outbreaks. Rebekah, I don't know if you want to talk about some of the experience that we're seeing and what that translates to in terms of mitigation efforts there.
Yeah, there was a question about whether or not we should be encouraging 2 to 5-year-olds to mask, because, and I have 3 children, so I'm feeling this, because they chew on their masks, they play with their masks, they stuff things inside of their masks. My 7-year-old, who is well above the age of 5, cannot keep a mask on without chewing on it. And so I feel that, right? Like I understand that frustration. I still do want to encourage mask wearing for those ages. I think it's still effective. It's still helpful. If they take their mask off, you just remind them to put it back on, because what we're doing with masking is reducing the amount of virus that is out there in the air, able to be inhaled by someone else. And so even if they're only wearing their mask half the time and you spend a lot of time trying to tell them to put their masks back on, it's still worth it. We're still reducing the overall exposure to other people.
The other question, and Rebekah, you mentioned this before, just to clarify that exposure is unmasked close contact for 15 minutes. Is that correct?
So it's within 6 feet for a cumulative total of 15 minutes, regardless of mask wearing. And that can be 3 5-minute intervals. It can be 1 10-minute, 1 7-minute conversation, but it's over the course of 24 hours. If you are closer than 6 feet with a positive person, with an infectious person rather, then that's considered an exposure. And if unvaccinated, you'll be asked to quarantine even if you were both wearing masks. The only exceptions for those are really hospital settings where doctors have been professionally fitted with respirators. And so that's not necessarily applicable to this situation.
Seeing some questions around playing musical instruments. The shofar, we will say that we had a whole shofar conversation previously. Or blowing into a horn or anything else and concentrating your droplets. Please do everything you can to be safe and distanced.
Yes, and that does relate to the very long question earlier about band playing instruments. Anytime, the 6 feet and 15 minutes is based on a regular conversation and the amount of respiratory droplets that typically leave your mouth and hover around and then settle in that context. And so if you're singing or playing the clarinet or blowing the shofar or even like increased respiration, you could be playing the violin very passionately. And if you're playing Tchaikovsky with lots of passion, your respiratory rate is going to increase and you may be, so I think the thing to consider is in those settings, singing or playing an instrument, you are projecting respiratory droplets a little bit further or a lot further, depending on what you're doing, than you normally would. So it is worth exercising increased caution.
Only Tchaikovsky, though, not Mozart.
Well, I'm a fan of Bach, but I listen to the cello concertos, and they're much more mild.
So I want to be respectful of your guys' time. We have a couple quick ones. How often should cloth masks be washed? And there's been early on, and I think it's come out of the conversation now, how long does the virus, both Delta and the regular one, live on surfaces?
Wash your cloth masks after every use if you can. I will keep masks in the car for my kids. So if we are, and myself, so if we're running into a grocery store, we put them on, we get back to the car and I leave them in the car. I have to admit that I don't wash those every single time, but when they've been wearing them all day at school, when they've been wearing them for more than just like a quick run into the grocery store, always wash them. And if you ever have looked at your children's masks on the inside, they're disgusting. So please, for many reasons, for bacterial infections, please wash your masks. And living on surfaces. So we're not seeing a lot of spread from what we call fomite transmission, which is just, I touch this coffee cup and then I put it down and then my kids come along and drink from it and they have touched it and then they touch their mouth, right? We see there are a lot of respiratory viruses that spread very efficiently like that. And we're not seeing that as much with Delta. So while we're still recommending cleaning and sanitizing, we're really emphasizing a whole lot more this like face-to-face interaction, masking, distancing, that sort of thing tends to be a lot more effective.
I'm going to come back to my friend Jonathan's earlier question here about organizations, reopening plans, returning to offices. I think a lot of people are asking questions about. The guidance again is if you are in indoor public spaces, which most workplaces would qualify as, employees should wear masks. And if they've got their own office space and then they don't need to wear masks in that while they're in their office. So I don't know, Jonathan. It's a pretty interesting time. I think every organization is thinking through what's the pace that we bring people back. Some things are just better done in person. And so the way we're handling this as an organization is that we are optimizing virtual work wherever we can. When there are things that we really need to be in person for, then we do it safely. And so I think that kind of speaks to maybe a larger theme in all of this, which is that COVID is not going to disappear after the tail end of this Delta variant. We are going to have some version, some form of COVID living with us in the background. And so at different times, we're going to have to adapt and figure out how do we do the rest of our life safely. When we get to a point where most people are vaccinated, this will be way easier. But in right now, there's a need to be a little bit more careful than we would otherwise. And so I don't think, to succinctly answer your question, I think it's fine to start making plans to bring employees back. I think you just need to do it safely. And then if it works to keep people virtual, then let's do that.
I've seen some schools questions. I do want to just say too, and Danny sort of alluded to this earlier, but we are actively working with public and private schools in Richmond and Henrico to help promote the safest mitigation measures possible. So we have a question here about whether or not it's safe for children to be eating indoors when they are not old enough to be vaccinated. And that, in those situations, we try to work with the schools and we say, how can we eat in the classroom? Like, can we keep people at their desks because then they're with their cohorts anyway, the people that they're with all day anyway. And each school will take a different approach. So I can't I won't give you this must be done because you have to do what works for your school. But to the maximum extent possible, we keep the unvaccinated kids distance from each other as much as we can. If it's a lovely day outside, absolutely eat lunch outside, right? But that's not always possible. So we're not going to we're not going to set a standard that we can't hold, because I can guarantee you none of my 3 children are going to eat lunch outside when it's pouring. Or even when it's as hot as it has been this week. Even that is a little icky. So it is, concerning. And there are lots of areas where we see potential risk. And our job then is just to mitigate that risk as much as possible. And then work with the consequences if there are some exposures, and then continue to contain that so there's no further spread.
Keeping on the school theme, there was an earlier question about quarantining in schools and then masking and vaccinating in schools. So the CDC recommendation for K through 12 is universal masking. And that really comes in the context of having a large swath of the population that doesn't even not eligible to be vaccinated, and then continuing to have relatively low vaccination rates among the 12 to 18 population. Our local school systems, at least the ones that we're engaged in Richmond and Henrico, are in different places, and they're still, it's still evolving. So Henrico right now, their board is voting tomorrow, actually, on what degree of mask requirement will they have. And I think, it's important to recognize that where folks end up on this is not. It's not that people would be against the mask mandate or for a mask mandate, but really thinking through, how do you operationalize a mask mandate? And what happens if somebody refuses to wear their mask? And does that result in disciplinary action against a faculty member or a student? And so it's just a really complicated thing the school systems are trying to wade through right now. Where things stand in Richmond, they have been clear that they will follow the CDC guidance and do universal mask requirements. They are also in the process of weighing whether they will follow the city's pathway to require vaccination, or whether they will do vaccination or a testing option. So that's still being worked out. I haven't heard any updates on what that will look like in Henrico. But the other big piece of this is, when we invariably find a positive in the school setting, one of the things the schools are going to have to get really good at, and Henrico's had more practice because they've been in person for longer, but to really document and enforce seating arrangements, cohort seating, like really trying to figure out where kids would have had exposures to other children. And this is hard. And we just had an example at Patrick Henry School recently, where you probably saw articles yesterday where 3 classes were all fully quarantined, not because the entire class, not because we could definitively say the entire class had a close exposure, but it was because we didn't have enough information, because that particular school wasn't tracking where kids were seating. The kids were all kind of intermingled, and so the most conservative recommendation was, okay, let's just quarantine everybody. Schools will get better at this, but it's going to be a bumpy fall as we figure out how to actually do things like make recommendations around quarantining and isolation.
Thank you both so much. This has been super helpful. Just for those of you that are on the call, we are going to, you're getting some shakes in the screen there. We're good. We have recorded this and we'll share it on our social media channels. And again, if you have specific questions, the Federation is happy to be a conduit to Dr. Avula and Rebekah. Rebekah, are you an official doctor?
I am not, and it is
okay. Good.
It is something I have to always tell people, because whenever you have a title that ends in ologist, people just assume that you have more education than you necessarily do. So no, I am not. Although a recent Richmond Times article did call me Dr. Butterfield, and I didn't catch it till it was published. So.
Well, we will officially anoint you one of our key doctors here.
Oh, thanks, guys.
Anybody that brings the fuzzy.
Danny, you need a fuzzy now.
I do. I would like to share on behalf of the Federation and the community a couple of just quick things. The physical impact of this, the last 12 to 16 months has been devastating. Equally devastating has been the mental impact on our children, on each other. And I have seen great strength within our Jewish community when we have found times to come together, to talk to each other, to reach out to friends, and I would encourage you to do that. Here at the Federation, we have spent significant hundreds of thousands of dollars and resources to support those that are struggling financially and mentally. If you know of someone who could use a friend, needs a reach out, needs a hand up, please call our partners at JFS Richmond and the Richmond Jewish Care Line. The number there is 804-525-8299. It is a financial lifeline, but also a mental lifeline for so many. Please reach out. We are here together. I look forward to being in a room soon where I can give everybody a hug, have some challah, a wine, maybe even a scotch at that point together, and celebrate mitzvot and good simchas together again. On behalf of the Federation, thank you for joining us, Dr. Avula and Rebekah, our new Doctor of Knowledge. We are so grateful for your leadership of our community over the past 16 months, and we look forward to not having to do too many of these in the near future. Thank you all for joining us, and have a wonderful, safe day. I'm hearing some rain outside my door, so stay safe, and thank you all.
Glad to be with you all. Take care.
Thanks so much for having us.
Thank you.